Good afternoon, everybody. Please take your seats. Even VIPs, dear VIPs, VVVIPs, please take your seats. Honourable guests from the Government of South Africa, you are so welcome. It's so great to have you at the International Maternal and Newborn Health Conference 2023. Attendees, thank you for coming back after lunch. I know it's hard. Appreciate you. In the digital world and online, thank you for streaming with us. We see you, well, not literally, but we feel you. We thank you for that. I know that our watch party is happening. I've got a little bit of FOMO, fear of missing out, from your watch parties. Cameroon, hello. Uganda, welcome. The UK, this is a better watch party than that other one you had at the weekend. I promise you. All right. So, coming up in this session, we are going to be talking about where are we with the SDGs and maternal and newborn health. Where exactly are we between now and the next 7.5 years? That is going to be an important target. What are we going to do between now and the next 7 years will really make a difference. So that is what we will be doing in this session coming up. Also coming up, one of our esteemed speakers will be speaking Portuguese. Does anybody in the room speak Portuguese? Yeah. Mozambique is in the house. All right, very good. Go and sit next to everybody else and interpret for them. That's my plan B in case our AI simultaneous interpretation that we're piloting does not pilot. But if it does pilot, it's going to be fabulous. So what you will see, around the room there are little sheets of paper with a QR scan on for you to take a picture with your phone. If you don't have that little piece of paper, then also back here, there will be a QR scan on the screen. Just aim your phone at the screen, and then your phone will take you to Wordly. And Wordly will say, which of 29 languages would you like to have a transcript in? And then you select your language, and then you do join session, and crossing everything, it works. Also, you should be able to see a transcript in English on the screen as well. So there are multiple ways that you will be able to hear and appreciate our guests from Portugal. Hopefully that will work. I am on safer ground knowing how we are going to start this session with a very special keynote from the Honourable Minister of Health from South Africa, Dr. Joseph Phala. I know he's used to a very loud round of applause that will keep going for about 20 seconds while he walks to the stage. Oh, and cheering as well. Minister, you're popular.
Thank you.
Excellent. Welcome.
Thank you very much. Thank you. Thank you. Thank you very much. And thanks to our very energetic program director. Let me recognize my colleague, the Deputy Minister for Health for South Africa, Dr. Dlomo, Minister of Health of Equatorial Guinea, and also colleague, the Minister of Health of Liberia, our MECs, maybe because they're also guests from other countries. MEC stands for Member of the Executive Council, which means in other countries it will be a provincial or regional minister. So we have quite a number here from our host province, and also from Gauteng, from Limpopo. I think the MEC for North to West was also with us this morning. Our WHO Acting Assistant Director General and Aligned Maternal and Newborn Health Co-Chair, Dr. Anshu Banerjee, and also Country Director for WHO, Dr. Owen Kalua, always very supportive to our programs. UNFPA Regional Office Representative, Mr. Tulani Mbata, and a host of other senior executives and officials from various organizations, from the UN family, and various other organizations. Good afternoon, ladies and gentlemen. Let me, from the onset, thank the organizers for accommodating us, the South Africans, myself, and the Deputy Minister, and various other senior people also from the provinces, for accommodating us to say something to you this afternoon. I know that we were supposed initially to speak in the morning, but we had to report to our bosses, who are the members of parliament. So this morning we had to go and report to them and ask for budget. Now, if we didn't go there, we would not have a budget to finance our health programs. So forgive us for having to report to prioritize our bosses. It's not because we undermine this conference. So we really appreciate that. I must also thank the organizers for bringing this conference here to South Africa, because you had a lot of choices. You could have taken it anywhere else, but we really don't take it for granted that you came to our country. I want to acknowledge your steering committee for also proposing a very scientific approach to review collective action by countries to respond to the global challenge of high maternal and neonatal mortality. I've also noted that the objectives of the conference, which include collaboration, coordination, cross-country, and alignment within the maternal and newborn health community, sharing successes and effective implementation strategies, and identifying promising solutions to improve maternal and neonatal health, and also prevention of stillbirths, reviewing and recognizing country, regional, and global progress towards maternal and newborn health targets and milestones. Also prioritizing actions to accelerate progress towards meeting our 2030 SDG goals, and also developing the next generation of leaders. As part of our contribution to the agenda on the several objectives of this conference, allow me to refer you to several global initiatives that started the journey some years ago. This includes the progress made through the implementation of the Maputo Declaration, a partnership in maternal, neonatal, and child health initiatives, and recently the Global Leaders Network. The difference now is the time pressure. We cannot continue at the current pace if we are envisioning to end and prevent maternal and newborn deaths by 2030. So time is not on our side. Recently, in 2018, countries converged in Nairobi for the International Conference on Population Development, commonly known as the Nairobi Commitments, which set forth a vision to achieve gender equality, promote, respect, and fulfill human rights and reproductive freedoms for all. Maternal and newborn experiences cannot be pleasurable moment for families unless if it happens in a free, safe, and respectful environment. As indicated in the theme of this conference, aligning together, accelerating together, saving lives together. As different countries, stakeholders, private sector, we need to join hands to create safe and pleasurable motherhood across the globe, irrespective of where one lives or the economic situation one finds themselves in. It is even more critical that we support families from countries with severe humanitarian challenges. I'm aware that amongst us there are representatives from such countries, and they continue to join forces with other member states to respond to the agenda of ending preventable maternal mortality and implementing every newborn action plan. I believe that it's appropriate that we put our hands together to acknowledge these countries who, despite conflict and turmoil, are trying their best to protect mothers and children. Let's applaud them for all the work in very difficult circumstances I'm sure that especially us in the continent, in the African continent, we can identify with this very clearly, as we know from time to time, and even as we speak. There are a number of, also from our own country, people who have been streaming through our borders at airports as a result of conflicts in the east of the continent, in the Sudan and DRC and many other places. So we must indeed appreciate the efforts of our colleagues in those countries. While SDG Goal 3 targets sounds ambitious and unachievable, we need to make every effort to continue to strive to achieve the reduction of maternal mortality ratios to less than 70 maternal deaths per 100,000 live births, and preventable deaths of children under 5 years of age to at least 25 per 1,000 live births, and to reduce also neonatal mortality to at least 12 per 1,000 live births. I'm also aware that the ENAP and EMPP community developed the 90-90-80-80 targets, which are 90% coverage in women accessing antenatal care, 90% coverage of deliveries conducted by skilled birth attendants, 80% coverage of women accessing postnatal care services, and 80% coverage of management of small and sick newborns, which aims to keep us focused. These targets are very important because they say that if you don't have a number, you won't be able to assess your achievement. While the full progress report will be launched immediately after this session, I'm told, allow me to congratulate the countries that have reached these targets. It is crucial that moments and opportunities like this are used to share and celebrate the learnings from others, which is one of the objectives of this conference. Some countries made significant progress initially, but the progress was slowed down or even worsened as a result of the COVID pandemic. Also issues related to climate change, challenges of economic circumstances, and also to complexities of clinical interventions required to respond to some of these challenges. The advent of the implementation of universal health coverage in the provision of high quality maternal and newborn health care is an essential component for us to achieve, which will assist us to regain the momentum through the implementation of universal health coverage, when everybody can access care irrespective of the costs of health care. It is therefore opportune that this first International Maternal Newborn Health Conference has been convened at a very appropriate time to review and disseminate evidence, assess progress, and determine specific priorities that need to be addressed. I believe that we also, it's our responsibility as South Africa to share a little bit of our own journey and the challenges that we are facing in this regard in the maternal, neonatal, and child health services. It's never been easy for us as well. I want to just note that as a country, we have reached 80% of coverage for postnatal care and also 80% coverage for access to management of small and sick neonates. It has been even more complex to respond to the other challenges of the targets. The challenges remaining are, for instance, access to antenatal visits, which we are still far from 90. We are currently, as a country, at 76. Access to skilled birth attendants is also lagging behind. Instead of the 90 target, we are languishing somewhere in the area of 78%. Other challenges responding to gender-based violence, including violence against pregnant women and children, remains a problem in our country. High teenage pregnancy rates, with the age of girls falling pregnant also getting lower, remains a challenge for us. But despite these challenges, there continue to be a bright light at the end of this challenging tunnel. Through integration of HIV care into routine maternal and newborn care, vertical transmission of HIV infection has been reduced from almost 30% in 2002 to less than 1% in 2022. So some progress has been made. Under 5 mortality has also declined from a high of 81 per 1,000 live births in the year 2003, from 81 per 1,000 live births in 2003 to 28 per 1,000 live births in 2020. So some progress is also there. Now, these declines can be attributed largely to our major program of rolling out HIV and AIDS antiretroviral treatment. Purposeful efforts of strengthening HIV management, antiretroviral treatment program to prevent vertical transmission has been implemented right across the country. This is one of the 2 success stories of our PMTC program, which will hopefully assist in eliminating totally vertical transmission of HIV and this will also improve the survival of neonates. The other contributors to the success are the introduction of childhood vaccines and improvement programs addressing social determinants of health, such as the introduction of social grants for women giving birth who have no income, and also food security programs which addresses also food security have also led to better outcomes. We do continue to battle the problems of prematurity, interpartum related trauma, which remain leading causes of death. Hypertension and obstetric hemorrhage remain a challenge contributing to maternal deaths. Infectious disease, infections from TB, HIV, re-emergence also of previously eradicated infectious disease play a part in both maternal and also neonatal survival. We are also realizing increasing numbers of congenital abnormalities that have now become contributing factors which also require quite robust interventions. The broader goals of reducing maternal and neonatal mortality are what we still need to focus on. The in-facility maternal mortality ratio declined from 147.3 deaths per 100,000 live births in 2011 to 93.1 deaths per 100,000 live births in 2019. But due to the COVID pandemic, we lost some of our coverage in terms of, as I've said, with the lockdowns and fear of visiting health facilities, we lost some ground in this regard, and there are a lot of disruptions, and we hope to catch up again. When looking at the trend, maternal mortality ratio declined from 276 per 100,000 live births in 2007 to 87 per 100,000 in 2018. I will not be doing justice if I omit to talk about stillbirth rates that still remain at a high rate of around 20 per 1,000 births in health facilities. This still needs a very serious attention. The interventions that are required will include, but not limited to, broad multi-sectoral socio-economic interventions aimed at empowering women, as well as implementation of specific focused interventions within the health sector. As government, we have worked hard to address some of the social determinants of health, which is only possible through working multi-sectorally. To mitigate factors that exacerbate vulnerability of young women and children, such as poverty, government has introduced, as I mentioned earlier on, the child support grants for women giving birth who are not having any income. The introduction of these grants have led to reducing dependency of especially these young women on male partners, so they can be able to look after their babies without depending on the male partners. But also contrary to what sometimes is a popular, argument of some people in our country, that these grants will encourage, multiple pregnancies, teenage pregnancies. But the actual research shows the contrary. That actually, for the fact that the women actually are feeling safer, actually the contrary is that the unplanned and unwanted pregnancies have been declining notwithstanding what other people suspect would be a perverse incentive. The fight against social ills such as teenage pregnancy, which will contribute towards early school dropout and consequently leading to inability to finish school, and by that not also leading to difficulty in finding jobs. Our department, the health department, has partnered with our education colleagues through integrated school health programs. It is through this program that there has been an increased access to sexual and reproductive services for children in schools as young as 12 years of age. Again, it's not been an easy path. Some religious leaders have been very much against that, feeling that taking sexuality education to young children is not in line with their religion. But we've navigated that, and I think there is progress. Our sister departments in the education sector have really come to the party by keeping pregnant young women in school, supporting young people in tertiary education through a program called the Higher Health. Our government has developed strategies to improve economic conditions for women, young girls, and also people living with disabilities. The Department of Health ensures that all women of all ages have unhindered realization and access to sexual and reproductive health rights and services. Our commitment to multi-sectoral action is illustrated by the fact that our department and other departments are also represented in this conference. So that shows the extent to which we approach this. We see this as a multi-sectoral project. We are convinced that the main problem solver for these problems is the strengthening the health system to ensure and assure access to universal health coverage, as I mentioned earlier. This makes a stronger case for our unrelenting drive to the realization of the implementation tool in our country, which is the National Health Insurance. And again, I can mention that our presence in Parliament this morning was also to give support to urge the parliamentarians, because the law on this National Health Insurance is sitting with parliamentarians who must finish it in the next few weeks. So we had to give them a bit of encouragement this morning, that they must not shy away from passing this law so that we can move closer to universal health coverage. Health system strengthening has become our golden target because weaker health systems undermine universal coverage. We need stronger governance and leadership at all levels, good management of commodities such as medicines, vaccines, research and development, appropriately skilled human resources for health in the proper and appropriate numbers, also appropriate infrastructure. Of the other areas of health system strengthening, it is worth emphasizing that the health facility infrastructure is very key for providing good quality care for mothers and children. And this remains a challenge for us, which we are working very hard to achieve. So more needs to be done in terms of improving our infrastructure from primary up to tertiary level. We have, on our part, responded to some of the urgent needs, and one such response has been the prevention of avoidable maternal and neonatal mortality through the establishment of the Ministerial Committee, which focuses on monitoring maternal, perinatal, and child deaths, and on making recommendations of how these deaths can be prevented. Our government, we believe, needs to be also recognized and appreciated for having joined other nations of the world by removing fees at primary health care clinics and all the primary health services, thus ensuring that mothers have unhindered access to basic health services. Provision of free services for all pregnant women and children up to 6 years of age has been critical in improving access to antenatal, intrapartum, and postnatal care for all mothers and newborns. I may also emphasize that this is one of the legacies of our founding president of Democratic South Africa, President Nelson Mandela, because as early in his first term, in his first year, as President of the Republic, when we were all still doubtful as to what capacity we have, President Mandela stood in Parliament and gave a very clear instruction. At that time, I was also an MEC or a provincial minister in my province in the north, and we received this instruction. He said, I don't want to know whether you can say you are ready, you must implement free health for pregnant women and children under 6. And that has been maintained up to today. Emphasis has also been placed on ensuring that all equipment, medicines, and other consumables required to implement maternal and newborn package of care is in place in all health facilities. Availability of key medicines is monitored through an electronic digital system called the Stock Visibility System, through which from our headquarters in Pretoria, we are able to monitor the availability of stock in all our primary and also in hospitals. With regard to ensuring that every pregnant woman and infant has a full package of maternal, neonatal, and child health services, we have introduced some key interventions such as basic antenatal care plus, meaning 8 antenatal visits, and also early antenatal bookings. Integration of HIV care, including universal access to antiretroviral treatment. Also, this has been integrated into maternal and neonatal child services. Routine postnatal care, including immunization and promotion of early exclusive breastfeeding, and increased access to sexual and reproductive health services, including also, again, from the beginning, with a very serious resistance from some quarters, the termination of pregnancy also being as an available service. Skilled health workforce development has also been key, with considerable investment in training of doctors, midwives, and other cadres in what we call essential management of obstetric emergency management, and also management of the small and sick newborns, and also a program called Helping Babies to Breathe. Improving access to information has also been key. Audit of maternal deaths and perinatal review meetings based on health facility data have been used to identify and respond to the top causes of morbidity and mortality. Mothers and their families have been provided with reliable information and the opportunity to provide feedback where they have complaints or compliments through, again, a digital platform on the cell phone called Mom Connect, through which they are able to comment. We are proud that more than 4.5 million mothers have received messages through the support of this program of Mom Connect. We also ensure that every newborn receives a Road to Health chart, a booklet, which contains messages that support all aspects of early childhood development, including nutritional care, breastfeeding promotion, and also immunization. Ladies and gentlemen, these are indeed very ambitious objectives, some of which have been achieved, but a lot still need to be done. But I have no doubt that combined expertise, commitment, and energy of the delegates assembled here will be able to make significant progress and set in motion many more interventions that will bear fruit for all our communities from the different countries we come from in the coming years. As I conclude, it's my pleasure again to welcome all of you to our country. Welcome to Cape Town. Welcome to Table Mountain. Welcome to Robben Island. Indeed, welcome to the mother city, but above all, welcome to South Africa in attending this International Maternal Newborn Health Conference. But I hope that you won't end up here, because if you think you have seen some very interesting, things here in Cape Town, you ain't seen anything. Please visit other parts of South Africa. We have everything. We have the sea, we have the mountains, we have the Big Five. So I hope that in your planning, you did not aim to end up here at the Cape Town International Conference Center. You will be able to move around, including here in Cape, There's also various parts of this province and this city. But all the best. We're looking forward to the outcomes of this conference. Thank you.
The Honourable Minister of Health, who was doing double duty as the Minister of Tourism as well. How many portfolios does one minister need? Thank you, Minister. Appreciate you. The spirit of our conference, Together 2023, is collaboration, being inclusive. I intend to leave no acronym behind, just in case we use a couple of acronyms that you're not familiar with. If you're in this room, I know you know the answer to this, so yell it out. EPMM. Easy. Enough. Okay, don't sound so tired, because we are about to do the joint launch report for EPMM and ENAP, and we are going to start with Lydia Zigomo from the UNFPA. She joins us via video. Take a look.
Distinguished participants, ladies and gentlemen, please allow me first to express my gratitude to the Government of South Africa for hosting this International Maternal and Newborn Health Conference. Despite improvements over the last decade, the reality for pregnant women and newborns is tragic. Every 2 minutes, a woman dies during pregnancy or childbirth. Every 16 seconds, a baby is stillborn. And every 14 seconds, a child dies in the first month of life. The situation is even more alarming as the latest trends reveal that global progress to reduce maternal and newborn deaths and prevent stillbirths is stagnating. In some places, maternal deaths are even increasing. We are off track for the SDG targets for maternal and newborn health, and we must take urgent action. The burden of maternal and newborn mortality is borne disproportionately by the poorest or the most disadvantaged in low and middle income countries. And they are most at risk of increased threats from climate change, conflicts, and future pandemics. At this midpoint of the SDG era, renewed focus, alignment, and action to end preventable maternal deaths, newborn deaths, and stillbirths, which share many common risk factors, causes, and solutions, are critical. Most of these deaths are preventable. They happen because healthcare systems routinely fail women, girls, and newborns. Women die giving birth because far too many health services are unavailable, inaccessible, unaffordable, or offer poor quality care. We can and must do better by urgently investing in family planning and filling a global shortage of 900,000 midwives so that every woman and newborn can get the life-saving care they need. Ensuring universal access to sexual and reproductive health rights and choices, including equitable access to quality and comprehensive maternal and newborn health care services, lies at the core of the work that UNFPA delivers globally. UNFPA is determined to make this happen, but we cannot do it alone. The Every Newborn Action Plan, ENAP, and Ending Preventable Maternal Mortality, EPMM, initiative that we co-chair with WHO and UNICEF aims to support countries to improve maternal and newborn health and well-being. Let me end by saying what we already know and cannot stress enough. Women and their newborns rely on us. Progress will not happen without our joint commitment. Our commitment and partnership to end preventable deaths and morbidities needs to be as strong and inseparable as the mother and baby dyad. I thank you for your continuous engagement for women and their newborns, and I wish you all a successful conference.
When Lydia said most deaths are preventable, That struck a chord, that resonated, because I know that is why you are here, that is why you are working together, why we are in a hurry to make progress. The joint progress report launch is happening right now. We are going to unpack it for you, global trends and also key findings. Your unpackers, Alison Moran and Gagan Gupta. Alison is going to start the presentation, Gagan is going to conclude it, and then panel, we are going to debate it. Alison.
Thank you, Femi. Hi, good afternoon, everyone. It's great to see you all today, and thank you so much for the great opportunity to be able to be here with you today to share the findings from our first joint progress report on maternal newborn health and survival and preventing stillbirths. This is a joint report by WHO, UNICEF, UNFPA, and many, many partners. So we're really an honor to be here today to share with you where we are. I wonder if we can bring up the slides. Is it possible? Are they there? Oh, you can see them. Okay, fabulous. Sorry, I couldn't see you that far away. So first, just to acknowledge all the partners that participated and supported this report, as well as from the 106 countries who provided data to inform the report and the analysis. So thank you very much. So just to talk very briefly about the journey that we've made for Every Newborn Action Plan and Ending Preventable Maternal Mortality. This all started back in 2014 when the Every Newborn Action Plan was launched and endorsed by 194 member states at the 67th World Health Assembly. And then the following year, the Ending Preventable Maternal Mortality strategies were launched. Over the last couple of years, we've worked together as a partnership to really look at the maternal newborn dyad as well as preventing stillbirths. And we've developed joint targets that were launched in 2020 and 2021. And today we're launching the first joint report. So we're really excited to be able to work with you all through the IM&HC conference series to do another joint report in 2025 and use these conferences as an opportunity to share progress and think together about how we can really accelerate progress for achieving the SDGs, universal healthcare, using a primary healthcare approach. So just to remind everybody about our mortality targets, I know you've seen this already today, but we're all focused on achieving these mortality reduction targets by 2030. So a global maternal mortality average ratio of less than 70 per 100,000 live births, as well as a neonatal mortality rate of 12 per 1,000 live births, and a stillbirth target of 12 or fewer stillbirths. So that's what we're all working to achieve together. And we want to try to do that through achieving these coverage targets to 2025, which were presented earlier in the plenary this morning, but just to remind everybody about the 90-90-80-80 and really working together to get there. So we're looking at 90% coverage of 4 or more antenatal care contacts, 90% of births attended by skilled health personnel, 80% early routine postnatal care within 2 days of birth, and another 80% that looks at subnationally, ensuring that 80% of districts have coverage of these critical life-saving interventions, as well as ensuring availability of emergency care for both women with complications and newborns who are small or sick and need extra care, as well as really looking at the larger social determinants that really impact maternal and newborn health around empowerment, social determinants that we heard about as well this morning with the exemplars presentation. So I just want to reiterate that the targets that we have now do look at contact coverage as well as availability of emergency care. As we know, it's important to increase contacts with the health system that we heard about earlier this morning. But those contacts need to include quality and respectful care, as well as ensuring equity. So those are also critical pieces that we need to think about as a community. So this graph shows the results framework, or how we hope to get there as a joint ENAP, EPMM maternal newborn community. So in order to achieve those mortality targets, we need to work on achieving the coverage targets by implementing bundles of care, packages of care with quality and respect and equity so that we can really achieve the mortality targets. And all of this is supported by the 10 joint milestones of ENAP EPMM that you'll hear about a little bit later when my colleague Gagan presents. And just to say as well that we are also looking at measurement and how we better track not only the coverage and the impact targets, but also the processes and the care that's required to get to those coverage as well as impact indicators. And so we have a measurement improvement roadmap, which will be presented in more detail tomorrow morning at a plenary session, but look forward to working with you all to really strengthen that piece of it. As we heard this morning in the presentation by our colleagues from the Exemplars Project, that having data and using data really can make a difference in terms of improving programs. So just to talk a little bit about where we are with progress, where are we at our midterm point? We saw this morning that we've made some reductions and improvements in mortality reduction, but the key point here is that progress has stagnated. We still have 4.5 million deaths worldwide. That's maternal, newborn, and stillbirth. And as you can see from these two graphs, on the left is the maternal mortality ratio stratified by 5-year time period. And if you just look on the bottom at that purple line, that's the trends from 2016 to 2020, and you can see that progress has really flattened. Similarly, for newborn and stillbirth mortality rates, you can see since 2015 progress has plateaued. So we need to really accelerate progress to be able to achieve the mortality reduction targets. And you can see for maternal mortality, we require an annual average rate of reduction of 11.6, for stillbirth 5.2%, and neonatal mortality 7.2% for the period 2021, 22 to 2030. So we have a lot of work to do. In addition, we have these coverage targets, and we still have not achieved them. So we do have some work to do to be able to achieve those targets. And you can see that yellow line is skilled attendant at birth, the purple line is antenatal care 4 or more visits, and the blue line is postnatal care for women. And we still are not at any of those targets globally. And if we just look across regions as well, we can see inequities across regions where we see Central and South Asia, Sub-Saharan Africa are the two lines there that have the lowest coverage, but there are other regions that are lagging as well. So just to give one example of one country in terms of subnational inequities, this is just an example from skilled attendant at birth from Nigeria. Just one example. This exists in many countries. But if you look there, I won't go into the details. It's in the report. But you'll see the different states of Nigeria and the disparities, inequities in terms of coverage of skilled attendant at birth by different states. And then finally, just to talk a little bit about some of the broader social determinants, which is the APMM Target 5. And so what we're using as a proxy measure here is really looking at SDG 5.6.1, which is women of reproductive age who make their own informed decisions regarding sexual reproductive health and rights. And you can see there we're about 59% among the countries that reported data of the 48 countries. So we still have a long way to go. And we saw this morning in the earlier presentation that family planning, empowerment, and secular changes are all really crucial to improving maternal and newborn outcomes. So I just wanted to note that in addition to the report, which is now available on the WHO website and will be available in the conference materials, we also have country profiles for each of the 30 delegations that will be here for the rest of the conference, and then hope to do for additional countries in the future that outline more detailed information about where we are for each of these targets, as well as the different milestones. And we have a dashboard as well that's live that can be accessed to look at how we can track progress as a community over time. So thank you so much. I'm going to turn it over now to my colleague, Dr. Gagan Gupta from UNICEF for the rest of the presentation. Thank you, Gagan. Thank you.
Thank you so much, Alison, for setting it so well. And also echoing thanks to all the colleagues who are part of this report, including our fellow co-chairs from UNFPA. Over the next 10 minutes, I will take you through the key findings from the ENAP EPMM progress tracking. And as we stand at the SDG midpoint, with clear signs of losing momentum, what will it take to accelerate progress? Just to give you a brief historical perspective of the tracking, the ENAP tracking is based on the self-reporting by the countries, as mandated in 2014 by the World Health Assembly when ENAP was endorsed. Over a period of time, we have seen increasing number of countries, and this year we were able to break the glass ceiling by crossing the number 100 and bringing the maternal and newborn tracking together. And now it's joint ENAP EPMM progress tracking. During all this while, the tool also was revised to adapt to the different program needs. Now, where is this data coming from? This data is coming from exactly where the burden is. 58 out of 62 countries from the 2 regions with the highest burden, the Sub-Saharan Africa and Central and South Asia, have reported. We have 9 countries reporting from Latin America, the region which saw maximum disruption after COVID, and the region which has shown increase in the maternal mortality in the recent report. We have small island countries from Asia and Pacific, which are very important for equitable progress. We also have a very high reporting rate from the countries which are off track for both maternal, newborn, and stillbirths, and also the countries which are conflict affected. So we have now reasonable data from these countries to act upon. Now, having seen a bit of the background from where the data came, let's now move to the key headlines from the ENAP EPMM tracking, and more importantly, what it means in terms of the country actions. The first thing which comes out very clearly is stillbirths continue to remain under-prioritized. If you see, 83% countries have a national target for maternal and newborn mortality, but only 31% countries have a set target for stillbirth. And this has remained at the level of 25% since 2016. So not much progress in the SDG era on the stillbirth. And it's not only about the target setting, it is also stillbirths are missing in the programming. If you look at the MPDSR, very good progress on maternal death reviews. 90% countries are now having a policy for maternal death reviews. But only 58% countries include stillbirth. So as you go back home, there are 2 very clear actions from this particular slide on stillbirth moving forward. The second thing is the subnational focus is missing in the programming. If you see the national plans, 87% countries reported that they have a national plan for MNH. But if you look at the district plans, only 36% countries reported to have district plans. And at the beginning of SDG, we were at 33% for the district plans, so not much has moved. And when we sit together on Friday for the country engagement, that will be an opportunity where we try to sharpen our focus on the district and the provincial planning. Also for the countries which have national plans, the key strategies for 2 very important interventions, emergency obstetric care and small and sick newborn care, is missing. Only half of the countries reported to have a national strategy on 2 very high impact interventions. Coming to financing, 61% countries reported to have a costed MNH plan, but only 12% said that MNH plan is fully financed. And more importantly, the 2 very important high impact and high cost interventions, emergency obstetric care and small and sick newborn care, they are very much under budgeted. Moving to further what COVID has caused, the disproportionate impact of COVID on MNH allocations. There is a 40% decline, 40% countries reported to show a decline in the allocations in the MNH budget post-COVID. Also, 35% countries did not have data on this. But the impact is more disproportionate in the countries which are affected by conflict, where 83% of the countries reported that a decrease in allocations happened. And if you look at the regional variations, the 2 regions with the highest burden of mortality, the Sub-Saharan Africa and Central and South Asia, the elasticity to absorb the shocks of COVID in terms of the financial part was much lesser in Sub-Saharan Africa, where 77% countries reported that there was a reduction in the allocation. Now, moving to the private sector engagement remains suboptimal, be it for strategies for contracting private sectors or be it for data reporting from the private sector. And in regions like South Asia, private sector is a very important player. If you look at the accountability part, if the data sharing is not there, it becomes very difficult to ensure the accountability and the quality assurance. And things like C-section rates, early initiation of breastfeeding, antibiotic usage, stillbirths, and asphyxia are equally an important problem in the private sector. There has also been an inequitable progress in providing the financial protection. We heard in the morning Professor Campbell speaking on it. We heard the Honorable Minister speaking about the South Africa thing. But 71% countries have been able to exempt the maternal newborn health services from the use of fees. But if you look at the insurance schemes are much lesser. And when you divide this data by Sub-Saharan Africa and South Asia, again, for Sub-Saharan Africa, it is just 26%. Now, moving to a very critical component that is a major determinant of quality of care, the human resources. There are gaps in planning, deployment, and retention. 51% countries said they have a national strategy for human resources. Not much progress since 2018, when 43% countries reported to have a strategy. But what is also worrisome is only 29% had a provision for ensuring the retention of health workers. And we tried to look at the qualitative data as well. And there were two sets of things countries have done. One is the financial initiatives and the non-financial incentives. Now, financial incentives were predominantly like hardship allowances, risk allowance, housing, a rare skill bonus by some countries, free education by Kazakhstan, and then a lot of non-financial incentives like career progression, awards, workplace safety, and wellness program in South Africa. And a few countries also went for administrative things like compulsory rural posting, which was reported by Pakistan, Yemen, and Sudan. Now, coming to the data, there is a clear lag between when the global guidance is issued till the policy change happens in the country, till it is adapted in the data systems. And 8 ANC contact is a classical example. 59% countries said that they have a policy of 8 ANC contacts, but only 36% countries actually have that to capture in the data system. And when you look at the integration of the key interventions in the HMIS, we have got very good progress in recording institutional delivery, the C-section, and the low birth weight. But the progress on neonatal resuscitation and kangaroo mother care remains below 50%. Coming to the communities and accountability and the community health workers, the community engagement is missing, whether it is planning, whether it is accountability. And taking the example of community involvement in MPDSR, only 36% countries said there is a provision of community involvement in MPDSR. And it's not only communities that are missing, it is also the families, be it the birth companion in the labor room or the mother in the newborn care unit. So now moving from the milestones to the two emergency maternal newborn coverage targets. The ENAP target 4, which is on small and sick newborn care. The target aims at 80% coverage at district level. But if you see, the level of ambition is not even matching the proposed target, because only 50% countries have planned for 80% coverage by 2025. If you look at the implementation, it's even lower. With Sub-Saharan Africa, only 10% of the countries said that they have achieved the target. So we will need to do a lot of work in redesigning this target in terms of the country level work and in achieving the target. Now, coming to the EPMM target 4, which is emergency obstetric care, you see a drastic difference. There, the countries have overplanned, with nearly half of the countries planning above the recommended norms. But they have underachieved because overplanning led to scattering of the financial resources. And if you see in terms of achievement, only 36% of the facilities in Sub-Saharan Africa, which were designated EMOC, were functional. So as I conclude, and as we are at the SDG midline grappling multiple headwinds, and as Alison so eloquently showed that the progress is slowing down, we leave you with 5 messages and 5 priority actions. This is based on the data you have reported in your country reporting. The first and foremost is the level of ambition and investments must match the targets, especially for the emergency newborn and obstetric care. It will be important to go back on the drawing board, relook at the targets and investments around this. The second important thing is local implementation is going to be critical for the national progress. And here, having the sub-national plans to address equity will be very important. And countries like India have done extremely well in having a sub-national plan which has been fully budgeted and resourced. The systems needs to be adapted to deliver quality care. Quality has to follow coverage. It cannot be an afterthought. We saw in the morning by Professor Campbell, it is one of the 4 drivers. And it's a combination of infrastructure, human resources, equipments, referrals, and data systems. And 1.9 million stillbirths are a glaring example of missing quality in institutional delivery and antenatal care. Fourth, families and communities cannot be just clients and recipients of services. They need to be the partners in supporting services, be it the birth companion in the labor room, be it the mother in the newborn care unit, or be it community involvement in reporting and notifying deaths. And last but not the least, the data systems. And data systems require intentional shift, bringing synergies in the maternal and newborn data systems, reducing the time lag between policy change and capturing the HMIS, and 8 ANC coverage and KMC data is a classical example of this. So prioritize these actions in the off-track and the conflict-affected countries, and when we sit on Friday together, these are the things will help us to guide our work planning process. So as I conclude, I would like to say, we need to get out of our individual silos of maternal health, newborn health, child health, immunization, and within these silos, our own territories, because we are here for them. And that's what Align MNH is all about. Thank you so much.
Gagan, Alison, thank you so much for your presentation. Our brilliant panel will now come to the stage. We are going to take the joint progress report and look at some key themes from the country perspective. Dr. Alonge, come on stage. Dr. Benzani, please come on stage. Dr. Grandpierre, what are you waiting for? Dr. Jalla, hello, welcome. Thank you very much. I know it's the afternoon, but I know you've got more strength to applaud than that, audience. Thank you. Please take a seat. Thank you very much. Dr. Benzani, will you come and sit next to me? Is that okay? Come sit here. Fantastic. Dr. Grandpierre, sit next to Nigeria.
Yeah, okay.
Very good. Dr. Lade is representing Nigeria. Dr. Grandpierre is representing
Haiti.
Dr. Jalla is representing
Liberia.
Dr. Benzani, you are representing
Mozambique.
I love that you brought a crowd with you. I am not saying UK because there will be boos. All right. So, thank you, everybody. We listened to this joint progress report, key findings, a lot of really deep information, and I wanted to explore it for us from a country perspective, but really hitting those key themes so we get the most out of your experience and your country. Let's start with Nigeria. Financing and implementation at a state level. What are the challenges? How is Nigeria making sure that for MNH, that state level financing is a priority?
Thank you very much. Good afternoon, everyone. It's a privilege to be here on behalf of Nigeria. And I must say that the government in Nigeria has made a lot of effort.
Yes.
Like you said, implementation at the subnational level has been an issue because of the constitution of the nation, where the subnational does not really have to, they are not totally controlled by the federal government. But over the years, one of the plans and one of the activities and implementation activities of government includes the provision of a basic primary health care fund. That is the 1% of the consolidated fund of government, of federal government, to make sure that there is funding for primary health care at the subnational level. And this goes to all the states. It's primarily for the underprivileged. It's primarily for those at the poverty level to make sure that the the poor have access to basic health care. And this has been a plan of government so that at the subnational, there is counterpart funding, both by the states and by the federal government. And federal government is ensuring that there is implementation by making sure that the previous allocation for the states are accounted for before they are allocated for the next budget season, so that they want to make sure that there is implementation at the states level. That's one basic program that the federal government has put together. Another program that government has put together is what we call Impact Project. As a matter of fact, it's a loan from the World Bank to make sure that there is impact. It's not only for maternal health care, but maternal health care is majorly part of it, to make sure that transportation is available at the subnational level for pregnant women, for children in need of health care, to be able to access health facilities at the subnational level.
Thank you. I'm going to come back to you, but I want to talk about the importance of the quality of care. And let's use Mozambique as an example. Can you give us some ways that you have been trying to improve the quality of care in Mozambique?
Ok. Boa tarde mais uma vez a todos. Falando da abordagem da qualidade de cuidados em Moçambique, nós temos várias abordagens no país, em que uma delas foi a criação de enfermarias e maternidades modelos, e que isto aumenta aquilo que é a qualidade da oferta de serviços de excelência a nível das nossas unidades sanitárias, onde esta abordagem visa olhar alguns determinantes, alguns indicadores, e que um dos indicadores que nós monitoramos, neste caso da oferta de serviço a nível das nossas maternidades, posso aqui citar alguns exemplos, é a questão de contacto pela pele mãe e criança na primeira hora, o aleitamento do recém-nascido também dentro da primeira hora. Olhando para a parte do pós-parto, nós tínhamos muita complicação obstétrica, que uma das primeiras a nível do nosso país é a hemorragia pós-parto, e a abordagem que se criou foi de controlar esta mãe na primeira hora de 15 em 15 minutos, na segunda hora de 30 em 30 minutos, que é para melhorarmos aquilo que são as complicações obstétricas pós-parto. Isto está dentro desta melhoria de criação destas maternidades modelo. Temos outras abordagens, que é a questão da funcionalização de unidades neonatais a nível dos nossos hospitais, onde foram identificadas mais de 25 unidades hospitalares, dentre elas unidades distritais, provinciais e centrais. Quais foram os critérios de seleção destas unidades? Foi de acordo com as percentagens que essas unidades apresentavam em relação à taxa de mortalidade materna, as complicações obstétricas ao redor destas unidades sanitárias. E houve um investimento. Este investimento foi em formação contínua dos profissionais de saúde destas unidades sanitárias, que olhava tanto para os enfermeiros, tanto para os clínicos. Este pacote todo tem uma duração de 12 dias, em que é feita esta formação de modo que saiba-se usar aquilo que é a unidade neonatal, saiba-se dar seguimento, garantir que toda criança que esteja lá, que nasça doente, tenha um tratamento adequado. E os grandes benefícios disso é que nós aumentamos aquilo que são os internamentos a nível dessas unidades, porque diminuímos as transferências, porque os profissionais estavam formados, estavam capacitados, e aumentamos também o número de tratamentos a nível das nossas unidades sanitárias, e crianças também com alta clínica por melhoria a nível dessas unidades sanitárias. De forma geral, isto apoiou bastante, melhoramos muito aquilo que é a qualidade, mas também temos, a nível dos cuidados primários de saúde, falava da vertente hospitalar e agora falo a nível dos cuidados primários de saúde, em que também desenhamos um pacote de mentoria clínica. Nós trabalhamos com a Associação dos Pediatras e a Associação dos Gineco-Obstetras a nível do nosso país, e eles fazem parte deste pacote, desta mentoria. Então, esta abordagem visa desde o acompanhamento da mulher, desde a consulta pré-natal, maternidade, pós-parto imediato. Então, este pacote de mentoria ajudou a melhorar aquilo que são as qualificações das enfermeiras de saúde materno-infantil que fazem essa assistência, aumentando assim a qualidade. Versus também temos um pacote de formação de cuidados obstétricos de emergência, neonatais de emergência, em que este pacote nós fazemos uma ligação desde os institutos ou os centros de formação das enfermeiras, ainda na escola. Então, nós, como Ministério da Saúde, fazemos o alinhamento do nosso pacote, olhando naquilo que são as nossas maiores complicações obstétricas. Então, este pacote é desenhado e, frequentemente, fazemos a atualização do currículo da formação desta enfermeira que está a sair. Ela, quando sai, é prioridade. Formamos neste pacote que é cuidados obstétricos neonatais de emergência e aquelas enfermeiras também que estão em unidades sanitárias muito distantes, muito recônditas, que não têm facilidade de ter um apoio de um
Dr.
médico,
Benzani,
por exemplo. Sim.
you are telling me your entire health policy.
Yes.
It's impressive, but can I ask you very kindly to take a pause? Is that okay? Yes? All right.
Problem.
We'll come back to you, though. It's stunning and it's amazing. Thank you. You more than answered that key finding. I want to go into another one. Again, it's the Joint Progress Report, and we're using country examples to see what these key findings are and how different countries are approaching it. Maternal health, newborn health, or maternal newborn health, human resources. In Liberia, you have a human resources plan. Tell me and tell us how that fits into those resources for maternal newborn health. What's different? What's changing?
Well, thank you very much. Think about Liberia, 5.5 million people, 375 doctors. So we have to get creative. We have to look at the middle healthcare workers.
375?
Yes.
There are more people in this room than there are
Then
doctors in Liberia.
To cover all the patients. So we have to get very creative. We have specialists on a list, or we have them in school right now, but then we have to look at midwives. So some of the programs that we have designed, we have an OB clinician program where our midwives are trained to be able to assist the doctor or even do C-sections in remote areas. So right now we have 18 that we have deployed all over the country, especially in the rural areas. We have neonatal clinicians that are also taking the gaps for pediatricians and neonatologists. And we also have pediatric clinicians that these are all nurses or middle health care workers. Then we also have community health workers that looks at the people in the hard-to-reach area. So we have about 10,000 community health workers, but we have community health assistants, about 5,000 of them that are deployed in 5 kilometers away from the nearer health facilities. So they take care of the children. They do malaria care, diarrhea care, pneumonia care in those hard-to-reach areas. Then we have community health and supervisors that are from the facilities that supervise all of these community health workers. We have community health promoters, which includes your TTMs, which are your traditional birth attendants, that helps the mothers in the community to make sure that they make it to the nearest health facility, their babies get to the health facilities, and that helps to bridge the gap while we improve on the number of doctors, the number of specialists that we need in the country. So we have our middle healthcare workers take on these task sharing or shifting position, and that have helped us to decrease our maternal mortality as well as our neonatal mortality.
I can see from your face that it's working, but I'm going to ask you.
Yes.
How's it working?
It's working very well.
Is that something that you can share with other countries? Can you say, this is what we did in Liberia, this will work for you too?
Yes.
Oh,
Okay.
no hesitation. I love that. All right, Dr. Grandpierre, for Haiti, resilience in Haiti, almost in the same sentence all of the time, for many, many, many reasons. But building resilience to deliver quality care for mums, for newborns, how are you doing that in Haiti?
Thank you for your question. First of all, I do say that, as you know, in Haiti, we are French-speaking, so my English, understand?
It's perfect.
Sorry.
Très bien.
But what I can see, that overcoming challenges to improve quality of care for mothers and child and newborns is a priority task for our country. As a country, we are exposed regularly to natural disasters every year. And most of all, for the last decade, we have a climate of insecurity that not allows to pregnant women and to newborn to have access to services. So how we deal with this? First of all, by reorganizing and strengthening our community health system, by introducing the polyvalent health agent, the community health agent, with the working as the first level for the health system. They work as a link between the community and the institutional level. We use them in some specific tasks as vaccination, as a family planning, and in the new system that we involve in terms of maternal surveillance, death and response. Secondly, by adapting the IMOC approach, okay, allowing us to decongest, it's an English term, okay?
Yeah. Yes.
Decongest the maternity wards.
Yes.
Okay?
Yeah.
We have a strategy with basic amounts who are on the community level and managed by midwives, and complete amount on the departmental level where we are surgical services, anesthesists, doctors, etc. By building contingency stocks for furniture and medicines at district level to prevent stockouts. And finally, by strengthening the strategy of waiting house for pregnant women, placing them closer to the delivery centers so that they can have access in time on the services. By those ways, we have more results in terms of improving quality for mothers and newborns.
Doctors, I'm curious. I'm just going to wrap up, so I want to conclude here. But you worked, all of you worked with Gagan, you worked with Alison on this joint progress report. And I'm just curious about your experiences and where the similarities, where the differences are. What was it like? Talk to each other. Dr. Jalla, turn to your co-panelist, Dr. Grandpierre.
Yes.
The experience.
Oh, the experience working with the group, was done by mainly the Family Health Division. So they were able to gather all of the information that we needed to make sure that we were on this program in terms of forming our newborn NAPS program to make sure that we reported exactly what was happening in the country and how the plans were to reduce all of the maternal mortality as well as the neonatal mortality, and how we were going to bridge the gaps for making sure that the numbers of midwives and other medical practitioners were increased.
Mm-hmm. And in this lack of specialists that you have in Liberia, how you deal with the newborns, because you need specialists.
Well, we have pediatricians, but you have to, while you wait to train the specialists to become super specialists in terms of neonatal care, we have a neonatal program.
Okay.
So the nurses and midwives are trained in that program on how to take care of the neonates. So there's a special program. We graduate them, we set up a neonatal unit in one of the hospitals, and they are there as the pediatrician comes in to meet a neonatal specialist.
Dr. Longe, you are looking so thoughtful. Articulate the thoughts.
Well, I just know that Nigeria has been a part of Nigeria's implementing the district health information system, where there's data taken from the district level throughout the country. So we are able to monitor the data. As you see, during the progress report, it was clear, some data from the country. Some states were particularly doing well compared to some other states because the data is continually gathered. And there's so many factors because Nigeria is such a large country.
Really? How many Nigerians are there in Nigeria?
A lot.
Yeah.
Good answer, a lot. Audience, stand by. I'm going to give the last word to you, kind of virtually, but you have it, so stand by, be ready. Dr. Benzani, the experience of working on the Joint Progress Report, what is your biggest takeaway for us to share with us?
Ok. Em relação à preparação do relatório, chamando-nos a atenção, eu gosto muito de falar de qualidade de dados, a questão da nossa qualidade dos dados, a questão das nossas necessidades e, principalmente, a união entre a parte materna e a parte neonatal, que é um dos lemas da reunião, né? Together. E, principalmente, olhando aquilo que é o nosso financiamento, embora escasso, mas dá para fazermos muitas das nossas atividades, e olhando a questão da priorização, daquilo que nós como país, qual é a nossa prioridade neste momento para podermos garantir a funcionalização tanto da componente materna e neonatal. Então, este para nós foi o maior aprendizado, a questão da nossa priorização.
Thank you. Mozambique, you are the best hype team. Please come home with me. I want you to applaud everything I say too. All right, doctors, there is so much more to talk about. When are you going home, Dr. Longe?
When I'm going home?
Yeah.
On Saturday.
Okay, great. Dr. Grandpierre, when are you going home?
Saturday.
Okay, there's no wrong answer to this. Dr. Jallo, when are you going home?
Thursday.
Okay, Dr. Vanzini, when are you going home?
Saturday.
All right, we have time for more chats. We've had fabulous doctors. But for now, that is it. And now attendees. Okay, this is a cliffhanger, and this is a question for you, but we will not give the answer until Thursday. Okay, Thursday. All right, what actions, attendees, virtual audience, are you going to take to improve maternal newborn health? As many as you want to select can apply. I'm hoping that they will be up there on the screen. Bring forward evidence to align financing with existing ENAP and EPMM targets. Remember, this is the actions that you're going to do when you go home. Help ensure implementation is focused at sub-national levels. Work to build stronger health systems that are synergistic, efficient, and integrated for the delivery of care. Work to strengthen and build new partnerships for women and newborns. One more option. Strengthen data systems and improve the use of existing data. That information, your answers, will be the cliffhanger to this plenary number 3. Dun, dun, dun. We do not know what your answer is. But for now, I would like to thank our plenary, all of the participants. Thank you to the South African delegation. We appreciate you. Thank you to our presenters for presenting. Thank you for attending. And thank you, AI simultaneous interpretation. Who knew it would work? Your plenary attendees. Thank you. Thank you.
You tried. You tried.
Thank you very much. Thank you. Yes, yes. Thank you. Thank you, Doctor.